Thank you. Oh, there you go. Thank you again, everyone, for joining MAPP Rounds. Today we have a special guest that does very cool research. So Dr. La Joie, hopefully I said that correct, is a researcher at the University of California in San Francisco. He works specifically in the Memory and Aging Center. So he originally trained in neuroscience and neuropsychology in France before moving to California as a postdoc to do his postdoctoral fellowship at UC Berkeley and then at UCSF. So in his research, he combines multimodal neuroimaging, fluid biomarkers, and neuropsychological tools to study the natural history of Alzheimer's disease. He has established very strong collaborations with neuropathologists at UCSF, Neurodegenerative Brain Bank, to help bridge in vivo and post-mortem measures of brain pathology and guide a careful and rigorous interpretation of in vivo biomarker data. So for those of you who are familiar with this research, I always find it very exciting. So we will leave questions for the end, but please feel free to write them in the Q&A as they come up, and then I'll read them at the end. So thank you again so much for being here, and you can share your screen and the floor is all yours.
Great. Thank you so much for the introduction. I'm really happy to be presenting my work and our work to your team. I wish I could be with you, but I guess we'll do this in the near future. Yeah, just a couple of things of disclosures. My funding here. Also, one other type of disclosure I wanted to make is about colors in this talk. And as I was putting the slides together in the last few days, I just realized that it is very colorful. And originally it was not for Pride Month, but I thought it would be a nice celebration. But the point, the reason why I'm bringing this up now is that we usually try to be consistent within a given paper. But you'll see that from one side to the other, because I'm combining data from multiple papers, the same colors sometimes mean something different on different slides. So I'll try to like walk you through everything, and I hope this will not be too much of a confound. I'll start by just thanking the people, all the people who contributed to this work, and Gil Rabinovich has been an amazing mentor for a few years now. And here I'm just putting pictures of our lab pre, during, and post-pandemic. And it's been really nice to be able to meet people a couple of weeks ago for a first drink together. Also, the rest of the Memory and Aging Center and the Alzheimer's Disease Research Center at the MAC, the people at UC Berkeley, and like you mentioned in the beginning, I'm going to be presenting a lot of collaboration with the neuropathologist, and so I wanted to highlight their contribution and their willingness to teach a biomarker and neuropsychology researcher like me. All right, so the key, I think the core of the talk today is really about the clinical heterogeneity of sporadic AD. And when we talk about heterogeneity, at least the way I study it, I'm going to be talking about different concepts, different dimensions. The first one is the age of onset. And we know that age is the main risk factor for Alzheimer's disease, but there's still a lot of variability in when patients develop symptoms. And we have this arbitrary threshold of 65-year-old for early versus late onset. We usually look at age of onset as a continuous variable because we haven't really seen convincing data that there was like two subgroups. But the one thing I want to make, the one point I want to make, especially talking to your group, is that a lot of people are confusing a lot of terms, especially when you say early onset Alzheimer's disease. A lot of people understand autosomal dominant. And I want to make sure that here in this talk, I'm only talking about sporadic AD. And also, I think this is very different from the data you have when you're studying the Colbos data. Is that for us, younger age does not mean younger, earlier clinical stage. It just means that people develop the symptoms earlier. The other dimension that we study is the clinical syndrome. And I think one of the main changes that happened in the last few decades is that the clinical diagnosis of Alzheimer's disease used to rely really on this typical progressive amnestic dementia, but it's been shown that it's not specific nor sensitive to Alzheimer's neuropathology. And so actually the clinical criteria have changed. In '84, they required memory as a predominant factor in the diagnosis of probable AD. And this statement disappeared in 2011. Instead, we know that a lot of other syndromes that are non-memory predominant are often associated with Alzheimer's pathology. The two I'm going to be talking about the most here are the logopenic variant of primary progressive aphasia, so kind of like the language variant of Alzheimer's disease, and posterior cortical atrophy, the visuospatial variant, but there are others. And of course, like these dimensions are conceptually orthogonal to the idea of clinical severity and how fast people progress. And there's a very nice paper that just came out in neurology from, I think this is any data, but from a Dutch group, showing the variability of clinical trajectory. Here, this is CDR of sum of boxes, so going up on the left, or MMSE going down on the right, in patients that are amyloid PET positive and had a CDR of 0.5 at baseline. So you can see that on average, you can run a model and see an average trend, but there's still a lot of variability here that needs to be accounted for. So we study all these different dimensions and their relationship. The one thing though is that we study them as conceptually orthogonal, but of course they are somewhat associated in different situations. And one good example is how, for example, ApoE4 impacts the presentation of the disease. Usually ApoE4 is associated with more memory predominant presentations, but also ApoE4 decreases the age of onset. So there are some factors that associate that impact multiple dimensions here. And in the rest of this presentation, basically what I'm going to do is relate all these dimensions of clinical heterogeneity and relate them to measures of brain lesions. And for this, I will be going back and forth between studies in neuroimaging, a lot of PET, which is what you have to do when you work in Gil Rabinovich's lab, and also data from the brain bank. Just a couple of points before I start showing the data. All the data I'm going to be showing, whether it's neuropathology or neuroimaging, this is all about patients at clinical stage of Alzheimer's disease. They all have a diagnosis of MCI or dementia. So I'm not going to be talking about preclinical AD in this talk. And again, I want to emphasize that even though we have a lot of early onset patients, none of them has a known mutation or associated with autosomal dominant AD. And actually, their family history is usually not suggestive of an autosomal dominant pattern. The other point that's really important is that in the two cohorts, again, neuroimaging or neuropathology, the data comes from the UCSF Memory and Aging Center and Alzheimer's Center, but they all have evidence for Alzheimer's disease. So not only they have a clinical diagnosis of MCI or dementia, but also all the patients from the in vivo data are amyloid PET positive, and all the patients from the autopsy data set have a neuropathological diagnosis of Alzheimer's disease. So when I'm talking about heterogeneity of clinical presentation, I am not talking about the heterogeneity due to quote unquote misdiagnosis, meaning patients who fulfill criteria, but actually don't have Alzheimer's neuropathology. A major caveat is that the sample we study are not meant to be representative of general population or general patient population. Our samples are intentionally enriched in these atypical syndromes and early age of onset. And unfortunately, our data so far is predominantly biased towards white and highly educated people, which is something we're working on now. And again, our samples are really kind of extreme cases of this spectrum of heterogeneity, but I want to emphasize that we're studying these variants to to study a broader mechanism. And there's a lot of evidence out there that even in samples that are not meant to be clinically diverse, like ADNI, all the ADNI patients are late onset, they'll have at least memory deficits. This is part of the inclusion criteria. And there's a ton of papers showing how there are subgroups of patients based on imaging or clinical data. So heterogeneity is really at the core of the disease. And the reason why we're so interested in this is that this matter of heterogeneity is a big problem when you're trying to use a one-size-fits-all kind of metric to measure disease progression over time, whether you're doing it with imaging or with clinical measures. Patients are different and progress different in different domains. You want to make sure that your way of measuring the disease and tracking the disease is going to be effective in everyone equally. So this is really a major point, I think, that justifies why we're so interested in this. First data I want to show is looking at these three clinical variants. So we have patients with amnestic Alzheimer's disease, posterior cortical atrophy, or logopenic variant PPA. These are their average amyloid maps. As you can see, amyloid PET doesn't really reveal major differences across variants. When we statistically compare, there's not much. It doesn't survive very robust thresholding. The data is really different with Tau PET. Tau PET imaging really shows a very nice and kind of expected overlap between the symptoms and the Tau PET pattern, with a major left predominant pattern in the logopenic variant PPA, consistent with the language deficits, and of course the more occipital and parietal binding in the PCA. There's also a little bit more, you can see here in the contrast, a little bit more medial temporal tau in the amnestic AD. So here it really looks like tau is mirroring the clinical presentation more than amyloid. And what's interesting is that when you're looking at the comparison between the variants in tau, it really looks very similar to what we can see with structural MRI. This is the comparison of the three subgroups using voxel-based morphometry. You can see logopenic variant PPA have more tau in the left perisylvian areas, also less gray matter volume, and so on. So this pattern has been shown by many groups around the world of a very nice matching pattern between tau and brain degeneration. The one thing we're interested in was to see if to study the temporal relationship between tau and MRI. And we have a subset of patients here, 32 patients who had imaging at baseline in our study, and came back later, around a year and a half later, and had another MRI. What we did is that we used this toolbox to measure precisely the brain change over time between the baseline and the follow-up visit. And then we looked at how the baseline measures of pathology related to this upcoming brain atrophy. What you're seeing here is just measures of global brain atrophy on the y-axis. So higher values mean more severe rates of atrophy over time based on the baseline measures. And you can see that in general, patients who had more amyloid, more tau, or thinner cortex to start with tended to shrink, to have a more brain atrophy in the future, but that was only strongly significant for tau. And when you actually put the three measures in the same model, only baseline tau accounts for the amount of future brain atrophy. But the thing is that here, we're only looking at a global measure of pathology or global measure of brain atrophy. And what we're interested in is looking at this topographical pattern, because we're very happy that with PET imaging, with imaging in general, we have this topographical information, which of course can't be available with fluid biomarkers, for example. And here you can see this is a real example, one of the patients in the study. You can see that their tau at baseline was really here in the temporal lobe, a little bit more on the left than on the right. You can see the same image masked here. And here, this is the map of brain atrophy with regions in red showing the regions that atrophied the most over time. And we ran this like spatial correlation analysis to kind of measure the spatial similarity between the maps. And you can see the relationship between baseline amyloid and future atrophy is not strong, as you can see visually. But the relationship between baseline tau and future atrophy is really strong. And this pattern was really observed in all 32 patients really strongly. In general, on average, baseline tau predicted almost half of the regional distribution of atrophy, which is really strong. But I think this is just a value, and I just want to show you this this example. These are 4 different patients on 4 rows with their baseline amyloid, their baseline tau, and their future atrophy over time. And this is just really impressive. We just put numbers and stats on these patterns, but really the data speaks for itself. And it was really impressive to see the patient come back from the follow-up visit and really be able to match visually what happened to their brain with their baseline tau scan. The other component I mentioned earlier is the age of onset. And again, here, our sample really has patients that we scanned in their late 40s to their, I think the older patient here is 95. And you can see that the patient's age when we scanned them did not impact how much amyloid they had in their brain. Again, here we're looking at the global amyloid burden. The pattern was very different with tau, with younger patients having way more tau than older patients. And this is the same sample I showed before. So we have all these different variants, clinical variants of Alzheimer's disease. And when we look at the different variants separately, it was actually very impressive to see how similar the pattern was. Within each syndrome, we see this steep decline, and the younger the patient, the more tau, regardless of what type of presentation they had. We also went a little further and looked into, again, here I'm looking at a global measure of tau burden in the brain, but we wanted to look at regional patterns. And here, this is a map showing you the darker voxels show you areas that had a stronger relationship between age and tau uptake. So this negative relationship that is on the plot, it was particularly driven by parietal and frontal, dorsolateral frontal tau. And so this is a pretty global effect. But if anything, I think what's impressive is how the temporal lobe doesn't really show this pattern. The temporal lobe burden does not really seem to vary with patient age. And this is where I want to make sure, again, that this is based on cross-sectional data, and I've had people get confused with this kind of relationship. We're looking at relationship between age of onset and tau, not with time. I'm not saying that tau decreases over time. And actually, it's pretty much just the opposite. We know this is a very nice paper from the Mayo Clinic where they showed longitudinal change over time. And like you can see here, younger patients start with more tau, and they also accumulate more tau over time. But this is a Simpson's paradox and stats where you see this relationship, but cross-sectionally, but it's the opposite of the longitudinal one. All right, so this is where we turn to the neuropathology data, because we were intrigued by this finding. And so we're looking at this now at this complete independent sample from the brain bank. It's 146 patients, all with a clinical diagnosis of Alzheimer's disease and a neuropathological validation of this diagnosis. And we use this method that was developed here by in the Greensburg lab by Catherine Pedersen, who was a research assistant, I think, with her at the time. And she quantified the density of neurofibrillary tangle in the brain, and especially they probed 6 regions. So these 4 regions you can see the lateral view of the brain and in the cortex, and then 2 hippocampal areas. And it's really interesting because, you know, as a neuroimaging person, I've always been told that the holy grail was to validate imaging with neuropathology. But I think the kind of metric of derived from neuropathology we use is really important. And what I'm referring to here is that all these patients, the data on the right is showing 4 different patients, 1 on each row. And they're all diagnosed with Alzheimer's disease. They have Braak stage 6. So the maximum of the Braak staging scheme. but still there's a lot of variability in their tau burden. The Bragg staging is not a quantitative measure per se, which is really important when we are trying to relate Bragg pathology to imaging data. And here you can see Bragg 6 patient with a lot of tau in their medial temporal lobe, with very little tau in the medial temporal lobe, and same for the frontal cortex. So we used this method that Catherine developed. And here we did the same in this subsample of patients in the neuropath brain bank, looking at how age symptom onset was associated with the tau burden. And here you can see, very similar to the neuroimaging data, that in these 4 neurocortical areas, we could see this strong decrease in tau burden with older age of onset. And just like in the neuroimaging data, we actually did not see this relationship in the medial temporal lobe. So there's this dissociation between the tau burden in the medial temporal lobe and in the cortex that is really reminiscent of Melissa Murray's tau subtypes from actually 10 years ago now. The other thing that we were interested in is to actually relate this lower tau burden in late onset AD to their clinical course and to their disease progression. Because we know from the literature, and it's been shown from decades now, that early onset Alzheimer's disease is usually a more aggressive disease associated with a faster cognitive decline and more severe rates of atrophy. And this is actually the data, the MMSE data from the neuropathological sample I was showing you. Here, there are a decline in MMSE over time. And you can see that this is just to quantify this effect a little bit more using linear mixed effect models. If you take a patient, based on this model, a patient at age 58 will lose 20 points in MMSE over 5 years in the study. And over the same time period, in our sample, a patient who's 74 will only lose basically half of this. So really, again, validating that in our sample, we do repeat this pattern of early onset being a more aggressive disease. And so to study this, we went back to the neuroimaging data set. And again, looking at how baseline imaging data could predict the rate of brain atrophy over time. And what we saw is that first, our younger patients here in the sample had actually more severe rates of brain atrophy over time, like what's been shown in the literature before. But running a mediation analysis in this data, we did see that this association between older age of onset and lower rates of brain atrophy was actually mediated by their tau baseline, their baseline tau burden. So basically, older patients have less tau in their brain, and this is probably why they have lower rates of atrophy. This is kind of like putting all the data together. But you know, one thing that was really interesting having access to this brain bank data set was that we could actually look at not just Alzheimer's pathology, but go a little beyond this. And you know, there's a lot of literature, and I've always loved these papers from Rush showing how pure Alzheimer's pathology was really the exception and not the rule, and that most patients had mixed pathologies. And so we looked at our brain bank data sets and quantified in all our patients. Again, the patients have path-proven Alzheimer's disease, but we also quantified 6 different neuropathological findings that often coexisted with Alzheimer's pathology. And this is a paper that's just in press in Brain right now that Salvatore Spina led at the MAC. And when you just simply count how many copathologies you find in the brain of our patients, you really see this like kind of stepwise increase in age of onset, with older age of onset being usually associated with more numerous copathologies in the brain. But you know, outside of just this overall trend, I want to emphasize that there's a lot of overlap, and we have a lot of patients who had their first symptoms in their 40s or 50s and still had 3 or 4 additional pathologies in the brain at autopsy. And going into the specific details of which pathology was found, Here, I'm just binarizing the data between early onset and late onset patients, just based on this 65-year-old threshold for the sake of visualization. But you can see that a lot of these neuropathological diagnoses were found in both early onset and late onset patients, but tended to increase and be more frequent in older patients. The one thing, though, is that this pattern was not observed for every pathology we measured in the brain. And actually, when we looked at CAA, so amyloid angiopathy, or Lewy body disease, they were both pretty frequent in the cohort in general, but also equally frequent in early and late onset disease. And so this is just interesting to see that this idea that co-pathologies are more frequent with age, it's true overall. It seems to be true in the sample, but it doesn't affect all pathologies the same way. So we're interested in seeing what it means for cognition in this patient. And here I'm just showing you the same data I showed before. It used to be gray. It used to be all together on one plot. This is their decline, patient's decline in MMSE. And here it's split between early onset and late onset. And you can see patients at different levels, different numbers of co-pathologies. And what the analysis showed using a linear mixed effect model is that we did see that like the decline was faster in younger patients. This is what we already discussed before. There was a steeper cognitive decline in younger patients. You can see it here. And the late onset patient declined a little slower and actually had a higher average MMSE by the estimated MMSE by the time of death. But in addition to this factor, we also see that patients who had more numerous co-pathologies in their brain had a lower estimated MMSE at the time of death. You can see here that for every additional co-pathologies at death, the patient had 1.4 MMSE point lower. So there seems to be an impact of this additional co-pathology burden on the cognitive status of the patients. Then I wish I could, we could do the same kind of study in vivo with imaging or fluid biomarkers, but I think we're in a interesting situation right now in the biomarker field, because the way I've been able to explain it the best is with a metaphor to spatial neglect. And I think we know that when you show this to a patient and they can only reproduce part of it. This is kind of where we are with neuroimaging right now. If you consider that the model is the underlying neuropathology, the ground truth, the biomarkers can only show you so much. And so this part that they can show us is what we can detect with specific biomarkers. So biomarkers of amyloid deposits or biomarkers of Tau, Alzheimer's Tau pathology, whether it's PET or CSF. But then we have this whole bunch of things that we know exist sometimes often, but we cannot really probe them. And I think this is where it's getting difficult to really accurately estimate how much impact the Alzheimer's pathology has using biomarkers, because this is all we can see. And the only exception to that is actually the vascular lesions. And the vascular burden is something that we can measure with different tools. Usually, there's a lot of MRI markers of cerebrovascular lesions. I'm just going to show you one short example, I think, that to me was interesting and very relevant. This is a work that Lauren Edwards did in our lab when she was a research associate. She's a grad student in San Diego now in neuropsychology, really brilliant student. And she asked this question. Basically, she was interested in looking at how Alzheimer's pathology versus vascular markers could explain cognitive deficits. And so here in this first sample of patients, she just ran a very simple analysis looking at associations between Tau and cognitive scores. So Tau and cognitive scores. And you see this like very beautiful patterns that you kind of expect, with memory being associated with medial temporal lobe Tau, executive function with like a broad cortical area, visuospatial with the posterior Tau, and language with perisylvian Tau. So this was great. And then she used this spatial pattern to assess in a separate group, in a completely separate group. She assessed the relative contribution of the tau burden and the white matter hyperintensities found with FLAIR imaging. And here, this is just one example. So in this second, confirmation sample, she measured tau in the region she identified in the first step of the study, and also measured global white matter hyperintensity, and showed that both actually contributed to language deficit independently. And when you repeat this type of analysis for all the different clinical scores, she could observe this pattern everywhere. Usually tau was a little more strongly associated with the cognitive deficits, but white matter hyperintensity volume still contributed significantly. And the reason why I think this is interesting is that, again, this is our local UCSF sample, that it tends to be young onset. I think they have an average age of 65 here. And this sample is by design not meant to have a very high cardiovascular risk burden. So even in a pretty young onset a sample that doesn't have major cardiovascular events, we still see an impact on this FLAIR imaging that's independent from the tau pathology. So back to the question about the contribution of co-pathologies and Alzheimer's pathology, I think this is definitely something that we're very looking for, having more markers of different pathologies, because we do think they contribute even in these younger patients. The last point for this part of the talk, the last part I want to mention, is the role of ApoE4. And I think, again, here we're looking at the neuroimaging sample. We're interested in looking at how it impacts amyloid and tau burden in the brain. And the first thing we saw was that there was basically no effect whatsoever of ApoE4 and amyloid PET. Again, all the patients are amyloid positive. We know there's a very strong literature on ApoE4 and amyloid positivity. But here, once you saw patients were positive, we didn't see an effect of ApoE4 on their severity or in the regional distribution of amyloid. The pattern was very different for tau. And what was really impressive was actually how focal this effect was. I'm showing the data, the analysis with two different statistical thresholds, one being pretty severe and the other one being rather liberal. But even when you loosen the statistical threshold, really this effect of ApoE4 really remains in the medial temporal lobe. And we looked at it in more details here with intrarenal tau PET signal with partial volume correction to make sure it was not biased by anything around it, controlling for age, for clinical phenotype, for amyloid, for severity, and there's still a pretty significant effect. And I think it's not only a very focal effect, but also a very interestingly reproducible pattern. And here I'm just showing an independent paper from, it's a group in Montreal that analyzed ADNI data and also their own triad data in Montreal, showed exactly the same very focal effect of ApoE4 on medial temporal tau. And there's, of course, this paper from Habs showing in controls this time the same effect of very focal effect of ApoE4 on medial temporal tau, whereas like age and amyloid status, or I can't remember if it was status or a longitudinal measure of amyloid, but age and amyloid have very major widespread effect on tau, but ApoE4 repeatedly showed this very, very focal effect. And again, in all these studies, the effect of ApoE4 was independent from, on tau was independent from amyloid. So just to summarize this first part of the talk, we did see repeatedly that the clinical variability was associated with tau and not amyloid differences. And that was consistent between in vivo PET and postmortem data. One thing that I think I've been thinking a lot of, and this is not really new, but I think I only realized this recently, is that we're always told that age and ApoE4 are the main risk factors for the disease, for Alzheimer's disease. But it's interesting to think of them as more than just risk factors, but also disease modifiers. And I think it is interesting how both factors are associated with a more amnestic predominant phenotype. ApoE4 from our data is associated with more tau in the cortex, in the medial temporal lobe, and older age is associated with less tau in the cortex. So through different kind of mathematical reasons, both factors are associated with a higher ratio of medial temporal tau compared to the cortex. And this is, I think this is a very reliable pattern that a lot of people have seen as well. I think the key question here is why do people have tau in different regions? I think it really remains to be investigated and solved. This is really the key question here. There's a couple of non-exclusive explanations, either genetic vulnerability factors, but also there's some very interesting findings and hypotheses about how some of these quote unquote atypical presentation of Alzheimer's disease, especially the logopenic variant PPA or PCA, might be more prevalent in people who had early life developmental differences. And there's data showing association between early life dyslexia and logopenic variant PPA, or more recent data on mathematical and visual spatial difficulties in early age and later development of PCA. One thing here is that we're not saying that dyslexia is a risk factor for Alzheimer's disease. We're saying that dyslexia might be putting you on a pathway to develop tau in these specific regions. And if you ever develop Alzheimer's pathology, the pathology might accumulate in some specific regions. And so it might have to do with how the brain was wired to start with early life, and how the tau propagation or the tau vulnerability was impacted by this pre-existing brain architecture. The age of onset story is really interesting. We saw from consistent studies that younger patients had more tau, especially in the cortex, with PET or autopsy data. We also, oops, sorry, I'm just going to go here. There's a little issue. We also saw that there are co-pathologies are frequent in patients regardless of their age, but they do increase with age of onset, and they're more frequent in older patients. We don't really know why. I think there's really interesting data actually coming from Boston, suggesting that there might be some biochemical properties that differ between the tau found in early and late onset patients. There's a beautiful paper from Simon Dujardin was showing that early onset tau, like the tau found in early onset patient had more seeding properties. And then this other paper that didn't show differences in post-translational modification of tau. So I think there's a lot of interesting data that needs to be figured out about the biology of tau and whether it's the same in these different variants. Maybe the type of pathology is not, the pathology again does not happen in a vacuum, and maybe it's the brain, the pathology that has a different pathway and based on different brains. And we can think that, if tau pathology happened to a 40-year-old brain versus an 80-year-old brain, the tau pathology is happening in a very different context. So maybe this is what explains different properties of the pathology. And then, of course, the idea that we find a more less tau in older patients for the same level of clinical impairment might be due to their co-pathologies, and the fact that older patients have more co-pathology, so maybe they don't need as much tau for the pathology to be significant. Then there's really this issue that I mentioned before, comparing it to neglect, about how difficult it is for in vivo biomarker or imaging people to accurately interpret the impact of Alzheimer's pathology when we see it in the brain. Again, because we can't see everything else. So it's very relevant, especially now especially in the last few weeks, to think about this, because this is probably going to have an impact on the potential beneficial effect of amyloid or tau lowering drugs in patients. And the one point I wanted to make again is that co-pathologies are common even in early onset patients. So this idea that early onset is a pure disease is probably not true. It's probably a pure disease, but there's still a lot of other things going on, and we need to really define how much it matters. And then, so I'm 40 minutes in, and I've managed to not talk about the elephant in the room. And when I showed this slide to some people in my lab, they really thought I was going to talk about aducanumab, but I'm not, because I think everyone has heard a lot and probably enough. What I'm talking about is that I've been talking about a lot of biomarkers, but right now I cannot have a conversation with anyone and say that I do Alzheimer's research and biomarkers without everyone talking about blood tests. And so I wanted to show a little bit data coming from our center on plasma biomarkers for Tau. And this is really a study that was led by Elizabeth Tyson, was a graduate student visiting from Amsterdam, and she was working in Adam Boxer's lab for a year or so. And I've been very lucky to work with her on this project. So we gathered blood samples from almost 600 participants across different type of clinical diagnosis. And so that includes a lot of Alzheimer's and FTLD cases. And here I'm just showing the data on plasma measures of p-tau217, kind of like the one of the most recent measures. And you can see that based on here, the clinical diagnosis on the x-axis and the amyloid PET status, the elevation of this marker was really impressively specific to patients who have a diagnosis, a clinical diagnosis consistent with what we expect of Alzheimer's pathology, MCI, AD, dementia, leukopenia variant PPA, PCA, also some patient with cortical basal syndrome. But specifically within these clinical syndromes, p-tau was really mainly elevated in amyloid positive cases. So that was really this is really nice data. We had subsample of this group that had autopsy data, and this is showing the p-tau217 based on their primary pathological diagnosis, whether it was Alzheimer's disease or frontotemporal dementia related to Tau or TDP-43. You can see that the increase is really really strong in patient with AD, and there's a little bit here of patient with FTLD Tau. But if you look at the caption here, they actually had coexisting Alzheimer's pathology for the most part, except for this little outlier here. But when you do a comparison of the Alzheimer's versus the other the FTLD cases, the area under the curve was 96%. So really really high. Same when we try to look at differences in this whole sample of plasma between amyloid PET positive and amyloid PET negative cases, we still saw this very strong discrimination. And this is putting all the patients together, but this very high discrimination ability also existed when we looked within a given syndrome. And here, when we look at patient with MCI or patient with cortical basal syndrome, where we know that a part of them has Alzheimer's pathology and part of them has something else, the relationship between amyloid PET status and plasma p-tau was really strong as well. Back to Tau. Here we did the same thing of looking at how Tau, p-tau in the plasma was related to Tau PET status. We dichotomized the data into Tau PET negative and positive. Here again, we have a very strong discrimination between the two groups. But I think the beauty of the data is also to not look at Tau PET as just a categorical variable, but look at it continuously. And this is the correlation we saw between plasma on the x-axis and Tau PET on the y-axis. Correlation is really strong, but I think what's really important for us is that the correlation is really driven by the amyloid case. All the amyloid negative cases have very low value on both markers, except for this outlier, because you always need a good outlier to look like real data. But in the amyloid positive group, we did see this very nice correlation between p-tau and Tau PET. And again, it goes really beyond just saying if people are positive or negative. And the last couple of slides I want to show you is really trying to investigate this and think about what is happening here and this positive quadrant here, like in patients who have Tau and amyloid, and do Tau PET and plasma Tau provide comparable information about how much Tau there is or what it means here. And so this is data that Nidhi Mundada who just joined our lab a year ago, has been working on. And here she's looking at our patients who have MCI or dementia and are amyloid positive see this very nice correlation like I showed before. And she first looked at how it related to demographic variables. This top panel here is what I've been showing you already a few times now, that early onset patients have more tau in their brain measured by PET, and we saw that with pathology before. And we actually also saw this with plasma. We see this association between age and plasma p-tau. The other thing that I haven't really mentioned, but I know that Rachel Buckley is attending, so I had to present this. We did publish a paper before showing that women, our female patients, had more tau PET signal than males. And we reproduced this in this subsample here. And we also actually see the same pattern with plasma tau. So it's really interesting how both biomarkers are kind of comparably associated with this demographic variable, although you can see the association tend to be a little stronger with tau, but tau PET, sorry, but it's interesting to see a similar pattern. And then I think the really interesting part is how these two markers of tau are associated with cognitive decline. And we had patients who had, all patients had MMSE value at baseline, and some of them had follow-up data. And so when you run a linear mixed bet model on this data, you could see that on average, all patients declined, but baseline tau PET signal was associated with baseline MMSE, and this makes sense. We've shown this before, but also you can see this interaction term here. The tau PET signal is also associated with the longitudinal decline in younger patients. Sorry, not younger. Sound like a broken record. Patients who had higher tau PET signal at baseline had lower MMSE and then steeper cognitive decline. Interestingly, we saw the same pattern with p-tau. Again, p-tau is associated with higher p-tau is associated with lower MMSE at baseline, but also a steeper decline. And what was interesting is that when we put all both biomarkers in the same model, then it's only like both markers were associated with baseline MMSE, but only tau PET was predictive of future cognitive decline. So really interesting data. Again, of course, by training, I'm a neuroimaging person, so I need to find reasons why PET is going to be more interesting. And I think I'm just showing here this again the same pattern of correlation between plasma and PET. And I'm highlighting a few patients. I selected them because they have the same plasma p-tau value, but they have a lot of different tau PET signal. And 0.7 here and for plasma is the average value. So I didn't do this complete arbitrarily. Here we have a patient who has a lot of tau all over the brain. You can see it's even off the scale. It's all around the brain. A patient with this executive Alzheimer's presentation, and you can see in the frontal cortex there's a lot of signal. The logopenic variant PPA with a very parietal and temporal predominant pattern, but with this left asymmetry. Another patient with logopenic variant PPA, and then a patient with amnestic MCI. And you can see there's significant tau here, but it's really tau PET, at least tau PET signal, but it's really mild compared to the other patient. And all these patients have the same p-tau value. So we need to probably better study what is the contribution of these two markers and what they can teach us. Summary for this part of the talk and the whole talk, actually. So want to emphasize that this data really, we're talking about a young sample of patients, mostly AD and FTLD, and again, a low racial, ethnic, and socioeconomic diversity. Plasma p-tau was consistent with global tau PET and also amyloid PET to detect the presence of Alzheimer's neuropathology. But even beyond this, within patients who are positive, plasma and PET showed similar association with demographic and clinical variables. So this fact that younger patients and females had more tau consistent with our neuropath data. And then we need to work a little bit more on this, but maybe look at how PET might be more predictive of future decline. And of course, I think before thinking about this data in a more clinically applicable way, we need a broader assessment in better groups. Of course, want to thank everyone again. I'm putting a picture of Amelia, Adrian, and Leonardo here because I've been working a lot with them. They have amazing data, but I couldn't squeeze it into this talk, so I'm still showing their data. And Amelia was a research assistant with us for 3 years. She's moving to Boston and starting working in the HST PhD program, so she'll be your neighbor. And I also wanted to say that we're always looking for people, and if you were not convinced by the science, I'll just show you pictures that I only took during the COVID, during my COVID walks in the last year. So I hope this is probably better than the science. Thank you very much.
Thank you very much. We have a couple of questions. And so we've added some of the people here so they can ask the questions themselves. So maybe Bernard, if you want to go first.
Hi, Renaud. Thank you very much for this wonderful talk. Yeah, I had at least 2 questions. One is, when you showed your model with the co-pathology from the neuropath data, you did not model the impact of co-pathologies on progression over time, and so your graphic looks like it does matter for cognition, but it does not matter for cognitive decline. Have you tried that model, and is the number of co-pathologies important for cognitive decline?
Yeah, that's a really great question. I'm just going to show this slide again, just for everyone to see what you were talking about in case. So basically, you're talking about the fact that these lines are basically there's no interaction between a number of co-pathologies in time. So the lines are all of different colors, are all parallel to each other. The reason for this is that we actually did test, it's in the paper, it's like supplementary table 10 or something. We did test this, it was not significant. So we selected the best model based on like, AIC criteria and stuff like this. It wasn't significant. So we didn't put it into the model. I'm wondering at this point whether it's like a power thing, because it's only 150 patients to model all of this. So I would love to repeat this in a broader sample. It would make a lot of sense, but we need to show it.
Then the second question, if I may, is this work is incredibly important for clinical trials, because as you're probably aware of, we are having patients screen failing for clinical trials because they don't have amnestic presentation. And many clinical trials are still not aware or not incorporating all this data. But the difficulty is that if we are having atypical presentation that we want to include in clinical trial, we need to have validated behavioral measures to track changes, to track drug effect. And those measures somehow needs to be comparable, if I may say, to the amnestic presentation, so that we can somehow say, okay, the drug is as effective in these patients, or no, it works differently, because that's an incredibly important question. So do you, or not you personally, but anyone in the UCSF team, works to try and make some comparable, like for topet, it's probably going to be easier. We can use SUVR or any metric in different regions. That will be more comparable, but for cognition, it's a very tough task.
Yeah, it's really an issue. Like I completely agree, and I wish I had said it as clearly in my talk, because this is really an issue. Like, of course, you mentioned that, these patients are usually not eligible for trials. Although, they do fulfill the criteria for Alzheimer's dementia, because it doesn't require memory predominant anymore. So it's like they should, but like it also makes sense in terms of psychometric, just like you said, because actually when you look at MMSE or CDR, actually we have this really interesting pattern that we see every single time when we have a logopenic environment PPA in our samples. They tend to have lower MMSE than all the other patients, but they have also like worse cognition on MMSE, but also they have a lower CDR sum of boxes, so better CDR sum of boxes. And it's really, it shows you, I always use this example to say, well, it really depends on your metric. And for MMSE, if your guideline, the sentences that you're telling the patients are too long, the patient is going to fail because of this, but their CDR sum of boxes is completely independent from this language deficit. So then you're not going to be as sensitive. And so I think we really have an issue, because like, I wish we could include all these patients in all the trials, but then we need to move away from, tools that were designed for this typical older onset memory predominant presentations. And I think there is work being done in this. I think the other thing, you know, we could consider is to, of course, it would require way longer trials and everything, but you know, maybe not having the only primary outcome as the cognitive decline, but has like an actual more, you know, fact like survival or you know, other factors that would be independent from how we measure cognitive decline. But there's a lot of work to be done here, and I think for PET or imaging as well, because if everyone is going to be measuring, like, you know, hippocampal volume, well, you might say that this patient is not progressing, but it's because the atrophy is happening somewhere else. So I think it's really so maybe just use global measures, but then you're like, it's not great. I think we need to develop more patient-tailored measures for this.
Thank you.
And then Rachel has a couple of questions.
Yeah, sorry, I had a million questions. I loved the talk, Renaud. Thank you so much. And Bernard actually asked a few of the things that I was thinking about, so it's excellent. And also, just before I ask a question, I just love your figures. You always make really nice visualizations of the data, so thank you so much for that. I know a lot of people say that to me as well. But I guess you'd already discussed the number of co-pathologies. I thought that was really interesting too, and it really is something that would be so nice to dig into. But I do see your problem with power, because you have the issue already of you know, more data on early onset. The other thing I notice is that, you know, the higher co-pathologies, there's just less data there on the whole. But I would be keen to also see number of pathologies maybe treated as a factor rather than and continuous. Maybe there is something to be at least eked out of the early onset if there's a faster transition or faster progression just in that higher than 3 co-pathologies versus something else, because there is, I think, visually seeing something like people staying somewhat stable in the lower level, but really dropping off at the higher level straight away from the point of capture. So just a thought. But the other thing that I was interested in, and I'm just trying to find where I put my questions in the end, because where is everything? Oh no, I've lost my question. I'm trying to remember what it was.
It was about this, I think.
Oh yeah, so the discordance is so fascinating. That was such a really interesting idea, and you're absolutely right to dig into this, because there is so much variance from one to the other, and I would love to see what the other angle would look like as well. You know, if you're going on the horizontal versus the vertical. So I really like that take, and I think there needs to be more of that done at the moment, of trying to dig into what's differentiating these two metrics.
Yeah, I completely agree. Like, you know, it's funny because I was you know, modifying my slides until last night, and then I saw this plot and I was like, well, you know, I need to be fair. I need to do the other angle, right? The other axis. But it was very late, so I was
yeah, no, fair enough. Well, I'll just wait. I'll wait for the preprint, and also the sex differences. So the thing that I thought was really interesting, because I think that Clara Villa Castellar, who's in our group, she's been doing a little bit of looking at sex differences in plasma markers with some of the autosomal dominant groups, which is really fascinating. So I think some of that data might be coming out for AAIC. But the thing that struck me, and maybe I missed it, but I feel like the effect size was a lot smaller in the plasma versus the tau. It looked like the sex difference itself, it may be there, but it didn't seem as it seemed a little weaker. Is that something that you noticed too, or is that just me? No, yeah. Okay, so.
Yeah, no, you're totally right. And actually, but you know, we also see this with the age thing. You know, the correlation is there, but it's like, it's smaller. I think there's less association with this measures.
Right. The one thing I actually wanted to ask you was about the age, because in Ruben Smith's paper, when they found that faster rates of tau accumulation in PET were seen in younger individuals, but also females, and I did wonder if the two combined were of interest, and maybe here it might be the same. I wonder if there was a sex and maybe an age. Anyway.
Yeah, no, this is great. I actually, you know, when I looked at this data, when we looked at this data and future progression over time, I do see in the sample a steeper decline in women. And it disappears when I put tau in the model. So I think it might be driven by tau, but we need more, we need a little bit more on this. And I have to mention, I didn't show it here. Oh, actually, I think I have a slide. Yeah, well, you know, Lawrence paper and tau PET showing more tau in females.
Yeah.
But in the SPINA paper, in the pathology paper, when we quantify, you know, the tau tangles, we do also see this pattern for females having more tau at autopsy. So again,
that's nice. That's just the same as what they see in ROSMAP and in FLAME.
Exactly. And I think, you know, every time I've looked at this quantitative measure of tau in autopsy and how it looks like with tau PET, I've been really surprised. I thought I made a mistake because they always look too similar.
Yeah.
And you know, you would expect at least something to not work.
Right.
Actually,
right. Science is like that, right?
We don't see any effect of ApoE here. So like maybe that's the one failure.
Although the ApoE finding is fascinating, but maybe so localized that it might be hard end of life to, I don't know. It is an interesting find. But thank you so much for the talk. It was really wonderful.
Thanks.
Well, thank you again, everyone, for coming. And thank you again, let's see, La Joie for joining us. And I hope everyone has a great weekend.
Thank you.
Bye, everyone.